Test, test, test. Okay, I think we can hear better now. Let's test ChatGPT. I think I found what makes the problems. Um, okay, 1, 2. All right. Let's get it on then. Let's just test ChatGPT too.
Hey, what's up? Hey, what's up? Hey, what's up? Hey, what's up? Hey, what's up?
All right, guys. So I'm gonna start the podcast. Today we're gonna be talking about macronutrients and also lung obstruction and oxygen therapy and stuff like that. So I have with me ChatGPT. First of all, disclaimer: I know the audio isn't good. I've bought a new device. It's coming in the next few days. So hopefully, yeah, the audio is gonna be 10 times better next week. And I'm also thinking of putting a nice board for us so we can draw different things. ChatGPT, let's get it on with today's topic.
Awesome, sounds good. Let's dive into macronutrients. Where do you want to start?
Um, I would like to start from another angle. Let's talk a bit about lung obstruction, but I want to clarify some terms so everyone's on the same page. Can you explain to us the difference between hypoxia and hypoxemia?
Hypoxia is when tissues don't get enough oxygen. Hypoxemia is specifically low oxygen levels in the blood, so hypoxemia can lead to hypoxia.
So hypoxia is low oxygen in the tissues, but hypoxemia is low oxygen in the blood.
Exactly. Hypoxemia is a cause of hypoxia, but there are other reasons tissues might not get enough oxygen.
All right, let's continue. Let's talk a bit about different masks in order to provide oxygen therapy. So, for instance, you have the simple face mask. Could you explain that to us?
Sure, a simple face mask covers the nose and mouth, delivering oxygen at higher concentrations than a nasal cannula. It's used when patients need moderate oxygen levels, typically between 5 to 10 liters per minute.
And okay, so it has holes to exhale the air can escape, right?
Exactly. The mask has side holes that allow exhaled air to escape, preventing carbon dioxide buildup.
Interesting. Okay, and let's talk about other devices such as the nasal cannula and venturi valves and mask and non-rebreather mask.
Sure, a nasal cannula is a lightweight, flexible tube with two prongs that go into the nostrils, delivering low flow oxygen. Venturi masks provide precise oxygen concentrations using color coded valves. Non rebreather masks have a reservoir bag and valves to deliver high oxygen concentrations without rebreathing exhaled air.
Tell us more about venturi mask, because I don't understand in what situations I should be giving venturi mask.
Venturi masks are ideal when you need precise oxygen concentrations, especially for patients with chronic obstructive pulmonary disease, or COPD. They deliver a specific oxygen percentage from 24% to 60% using interchangeable adapters. This helps avoid giving too much oxygen to patients who rely on their hypoxic drive to breathe.
Interesting. Tell us more about the differences in which diseases do we give which.
So, for COPD or other lung diseases where controlling oxygen levels is crucial, Venturi masks are perfect. For mild hypoxia, a nasal cannula works well. Non-rebreather masks are used for severe hypoxia, like in trauma or respiratory failure, where high oxygen concentration is needed.
Can you give me some examples of diseases and what we would be using?
Sure, for COPD, a Venturi mask is often used to avoid over-oxygenation. For pneumonia, a simple face mask or nasal cannula might suffice. In severe cases like ARDS or trauma, a non-rebreather mask is typically used.
Interesting. Okay. Can we elaborate? Sorry for sticking to this so long. So if I have emphysema, do I use any mask?
For emphysema, which is a type of COPD, a Venturi mask is often preferred to deliver precise oxygen levels. This
Why?
helps avoid giving in emphysema, the body's drive to breathe can depend on low oxygen levels. If we give too much oxygen, it can reduce their natural drive to breathe, causing CO2 retention and potentially worsening their condition.
Interesting.
Yeah, it's all about finding the right balance for their specific needs.
Okay, so let's talk a bit about non-rebreather mask then now.
Sure, a non-rebreather mask delivers high concentrations of oxygen, around 60 to 90%. It has a reservoir bag that fills with oxygen and one-way valves to prevent rebreathing exhaled air. It's used in emergencies when patients need a lot of oxygen quickly.
Hmm. So non-rebreather mask is for maximum oxygen delivery, and I assume that the problem is that it's a one-way thing.
Right? The one-way valves ensure no exhaled air mixes with the oxygen, giving the highest concentration possible. But it's crucial to monitor the patient closely.
Interesting. So, um, so wait. So a non-rebreather mask, you say, is one way.
Exactly. The one-way valves let oxygen in, but keep exhaled air out, ensuring the patient gets pure oxygen.
Great. And the Venturi mask is not one way. So when do I use nasal cannula? When do I use simple mask? And when do I use Venturi?
A nasal cannula is for mild oxygen needs. A simple mask is for moderate levels. Use a Venturi mask when you need precise control, especially for conditions like COPD.
Tell me more about this.
Sure, nasal cannulas are comfortable and allow for eating or talking. Simple masks cover the nose and mouth for moderate oxygen needs. Venturi masks give exact oxygen percentages, perfect for precise management.
Um, I still don't understand when I give what. When do I give nasal cannula? When do I get Venturi mask? And when do I get simple face mask? When do I use?
No worries. Nasal cannulas are for mild needs, like STAVI patients. Simple face masks are for moderate needs, like after surgery. Venturi masks are for precise control, especially in COPD or when exact oxygen levels are needed.
Interesting. Okay.
Guarda.
Um, let's talk now a bit about oxygen administration. So, um, can you explain to me what FiO2 is and what Henry's law is?
Sure. FiO2 stands for fraction of inspired oxygen, representing the percentage of oxygen in the air a patient breathes. Henry's law states that the amount of gas dissolved in a liquid is proportional to its partial pressure. So, higher FiO2 increases oxygen dissolved in blood.
Tell me about Henry's law one more time.
Sure. Henry's law states that the amount of gas dissolved in a liquid is directly proportional to the partial pressure of that gas above the liquid. So, if you increase the oxygen concentration, more oxygen dissolves in the blood.
That makes sense. Speak slightly slower and louder, please. And explain to me how exhalation occurs with the non-rebreather mask on.
Of course, with a non-rebreather mask, exhalation happens through one-way valves on the sides. These valves open during exhalation, letting carbon dioxide escape while preventing room air from diluting the oxygen.
Interesting. So, um, um, can we talk about so it has two sets of one-way valves, for inhalation and one for exhalation.
Exactly. One set of valves allows oxygen in from the reservoir during inhalation, while another set lets exhaled air out, keeping the oxygen concentration high.
And the target O2 saturations are different for someone that's acutely unwell and someone with COPD, right?
Yes, exactly. For acutely unwell patients, we aim for oxygen saturations around 94 to 98%. For COPD patients, we usually target 88 to 92% to avoid suppressing their drive to breathe.
Explain to me what happens at a high altitude. Do we have different fractional inspired oxygen, and then is the air thinner and the air pressure lower? What's going on?
Sure, at high altitudes, the FiO2 remains the same, around 21%, but the air pressure is lower, so there's less oxygen available to breathe in. This can lead to hypoxia, which is why climates use supplemental oxygen.
Tell me more about this.
So at higher altitudes, the air pressure decreases, which means there's less oxygen in each breath. This lower oxygen availability can cause symptoms like shortness of breath, headaches, or altitude sickness.
Interesting.
Supplemental
Okay, can we talk about airway resistance now?
Absolutely. Airway resistance refers to the opposition to airflow within the respiratory tract. Factors like mucus, inflammation, or bronchoconstriction increase resistance, making it harder to breathe. Conditions like asthma or COPD often involve increased airway resistance.
Interesting. Tell me more about this.
So when airway resistance increases, it requires more effort to move air in and out of the lungs. This can lead to symptoms like wheezing, shortness of breath, and coughing. Managing these conditions often involves medications that reduce inflammation or open the airways.
So, how does this resistance occur?
Airway resistance occurs when there's a narrowing or blockage in the airways, like from swelling, mucus, or muscle constriction.
Mm-hmm.
This creates more friction. And that increased effort can lead to symptoms like wheezing or shortness of breath.
I see.
Yeah, it's a common issue in respiratory conditions.
Okay, so let's talk a bit about how the friction is reduced by the distance and the slow movement of gas. And yeah, can we talk about the friction between a gas molecule moving faster than its neighboring molecule?
Sure, when gas molecules move quickly, they collide more often with the airway walls and each other, increasing friction. Slower movement reduces these collisions, lowering friction. The diameter and length of airways also play a role. Narrower or longer passages increase resistance.
Interesting.
Yeah, it's fascinating how these factors impact breathing.
So let's talk a bit about the equation R equals, I mean, I can't even try to do it, but it's inversely proportional to the radius and pi. And, can you tell us this equation and analyze it a bit for us?
Sure, you're thinking of Poiseuille's law. It describes laminar flow through a tube. The equation shows flow is proportional to the fourth power of the radius and inversely proportional to viscosity and length. So, a small change in radius dramatically affects flow.
Interesting.
It really highlights how crucial airway diameter is for breathing.
Okay, let's continue then. Let's talk about impedance. What is impedance?
Sure, in respiratory physiology, impedance refers to the total resistance to airflow, combining airway resistance and the elastic resistance of lung tissue. It's like the total drag against breathing.
Can you explain to me more? I don't understand what impedance is.
Of course, think of impedance as a combination of all factors that make it hard to breathe: airway resistance, lung tissue elasticity, and inertia. It's the total opposition your lungs face during breathing.
Um, so 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 it focuses it's forces that resist air from being pumped in by the ventilator.
Exactly. Impedance reflects how much effort is needed to move air in and out, whether it's your muscles or a ventilator doing the work. High impedance means more force is needed.
Interesting. Well, okay, that makes sense.
Great. Glad it's clearer now.
So, if there's a buildup of pressure in the early airways, what happens? Because airway resistance slows movement of air to the alveoli.
If there's pressure buildup in the airways, it can reduce airflow to the alveoli, making gas exchange less efficient. This can lead to increased work of breathing and lower oxygen levels.
Mm-hmm. Can you explain to me what is this small airways trumpet?
Sure, the small airways trumpet refers to the narrowing of the tiniest airways, like bronchioles. When they narrow, they create a high-pitched noise, similar to a trumpet, when air flows through them. This often happens in conditions like asthma.
Tell me a bit more about this.
So when the small airways narrow, airflow becomes turbulent, producing wheezing. This narrowing can result from inflammation, mucus, or muscle constriction, making it harder to breathe.
That makes sense. So, if I understood correctly, we have um, an airway trumpet. We have wheezing when we have an airway trumpet, and it's because it basically has the shape of a trumpet and the cross-sectional area decreases.
Yeah, exactly. So when you've got an airway that narrows like a trumpet shape, it creates turbulence as air moves through. That turbulence causes vibrations, which you hear as wheezing. It's basically a sign that something's obstructing airflow.
Mm-hmm. Okay, interesting.
Yeah, it can be pretty fascinating how the body signals these issues. If you think about it, wheezing is like a built-in alarm system for your airways.
Wait, so in small airways trumpet, do we have increase or decrease in the yes, total cross section?
It decreases. When the airway narrows, the total cross-sectional area gets smaller, which is what causes that turbulent airflow and the wheezing sound.
Can you explain to me why individually each airway at the bottom of the tree has a higher resistance than any larger airway, but in total, in parallel, the small airways are low resistance?
Sure, each individual small airway at the bottom of the respiratory tree is narrower, so it has more resistance to airflow. But when you consider all those tiny airways together, they're arranged in parallel, which means the total cross-sectional area is much larger. This reduces the overall resistance, making airflow easier.
Why? You just explained to me what happens. I want to understand why.
Got it. It's due to physics. When airways are in parallel, their resistances add up inversely, meaning the total resistance is lower. It's like having multiple lanes on a highway. More lanes mean less traffic resistance.
I see. I see. So, okay, that makes sense. But what does it mean that individual each airway at the bottom of the tree has a higher resistance than any larger airway? I understand the in parallel part, but I don't understand that part.
Individually smaller airways have a smaller diameter, which creates more friction for the air passing through them. So each tiny airway has a higher resistance compared to a larger airway, because it's like trying to breathe through a thinner straw.
I don't get this.
No worries, it's a bit tricky. Essentially, smaller airways cause more resistance because there's less space for air to move through, kind of like squeezing air through a narrow tube.
Okay, that makes sense. Okay, let's go to macronutrients now. So tell us about macronutrients.
Sure, macronutrients are the nutrients we need in large amounts: carbohydrates, proteins, and fats. They provide energy and are essential for growth, metabolism, and overall health. Each plays a unique role in the body.
Okay, let's talk about carbs now. We have monosaccharides, disaccharides, polysaccharides, if you oligosaccharides or whatever they're called. Uh, can we talk about these?
Absolutely. Carbohydrates range from simple sugars like monosaccharides, glucose, fructose, to disaccharides, sucrose and lactose, and more complex forms like oligosaccharides and polysaccharides, starch, fiber. Each type has a different role in digestion and energy release.
I see.
Yeah, it's pretty cool how they all break down differently and impact our bodies in unique ways.
And what is starch and cellulose? And we have non-cellulose polysaccharides, we have non-starch polysaccharides. Can you kind of explain these to us?
Sure, starch and cellulose are both polysaccharides, but starch is digestible and used for energy, while cellulose isn't digestible by humans. Non starch polysaccharides, like cellulose, contribute to dietary fiber, aiding digestion and overall gut health.
I see. So, what's the structure of a carbohydrate then? It's got has it what's the chemical structure?
Carbohydrates are made up of carbon, hydrogen, and oxygen atoms. Their basic structure is a chain of sugar molecules, ranging from simple monosaccharides, like glucose, to complex chains in polysaccharides, like starch. The arrangement and bonding of these sugars determine their properties and functions.
So it's got an alcohol in it, and it's called alcohol OH, and it's got carbonyl groups and hydroxyl groups.
Exactly. Carbohydrates have hydroxyl groups, OH, attached to their carbon chains, and some have carbonyl groups, C equals O, depending on the type. These groups are crucial for their chemical properties and how they interact in the body.
Interesting. Okay, and what's the function of a carbohydrate then?
Carbohydrates primarily provide energy. They're the body's main fuel source, especially for the brain and muscles. They also play a role in cell structure and signaling. Plus, fiber, a type of carbohydrate, supports digestion.
Interesting. Okay, and NSP, what's NSP? How does it connect to carbohydrate function?
NSP stands for non starch polysaccharides, which are a type of dietary fiber. They don't provide energy, but are crucial for digestive health, helping to regulate bowel movements and support a healthy gut.
Interesting. Okay. Um, let's talk a bit about dietary fats, but please tell us a bit more about NSP too.
Sure, non starch polysaccharides, like cellulose, are found in plant cell walls. They add bulk to stool, aid digestion, and can help lower cholesterol. Now, dietary fats are essential for energy, absorbing vitamins, and protecting organs. They come in saturated, unsaturated, and trans forms, each with different effects on health.
Okay, interesting. So, can we talk about dietary fats too?
Of course, dietary fats are categorized into saturated and unsaturated fats. Unsaturated fats, like those in olive oil, are heart healthy. Saturated fats, found in butter, should be limited. Trans fats, often in processed foods, are best avoided. They all play roles in energy, cell structure, and hormone production.
So, triacyl glycerol is the primary energy substrate stored in adipose tissues. Can you explain why this is true?
Triacylglycerols, or triglycerides, are efficient energy storage molecules because they pack a lot of energy into a small space. They have three fatty acids attached to a glycerol backbone, making them compact and energy dense. This makes them ideal for long term energy storage in adipose tissue.
What's adipose tissue anyway? Where do we find it?
Adipose tissue is basically body fat. It's found under the skin, around internal organs, and even in small amounts in muscles. It stores energy, insulates the body, and protects organs.
And what's the etymology of adipose?
The word adipose comes from the Latin adeps, meaning fat. It's used to describe tissues that store fat in the body.
I see. And so we have LPL, lipoprotein lipase, which kind of takes control of how much influx we have of TAG.
Exactly. Lipoprotein lipase, LPL, helps break down triglycerides in the blood so they can be taken up by cells for energy or storage. It
Interesting.
regulates how much.
Tell me.
So LPL acts like a gatekeeper, determining how much triglyceride rich lipoprotein gets into cells. It's especially active in muscle and fat tissue, helping manage energy use and storage.
Uh-huh. And so, okay, so why is this upregulated in the presence of insulin? I don't understand.
Insulin promotes energy storage, so it upregulates LPL to help cells absorb more triglycerides from the blood. This process supports fat storage and overall energy balance.
So, what do we mean by increasing palatability when it comes to the functions of dietary fat? And how exactly does fat carry essential fat soluble vitamins like A, D, E, and K?
Increasing palatability means fats make foods taste better and improve texture. They enhance flavors and provide a satisfying mouthfeel. As for fat soluble vitamins, fats act as carriers, helping these vitamins dissolve and be absorbed by the body.
Okay, let's talk a bit about protein function now then.
Sure, proteins are essential for building and repairing tissues, making enzymes and hormones, and supporting immune function. They also provide energy when needed and play a role in transporting molecules throughout the body.
Okay, and we have essential, non-essential, and we have conditionally non-essential. Can you explain all these to us, please?
Sure, essential amino acids can't be made by the body, so we must get them from food. Non essential amino acids are produced by the body. Conditionally non essential amino acids are usually made by the body, but may need to come from the diet during stress or illness.
What is this conditionally non-essential?
Conditionally non essential amino acids are typically made by the body, but during times of illness or stress, the body might not produce enough. So, we need to get them from our diet to meet increased demands.
So when, for instance, an essential precursor is missing, like tyrosine requires phenylalanine, what happens then?
If a precursor like phenylalanine is missing, the body can't produce tyrosine. This can lead to a deficiency affecting processes that rely on tyrosine, like producing certain neurotransmitters or hormones. That's why a balanced diet is crucial.
Uh-huh. Can we talk a bit about rapid growth now, like with arginine and proline, and how they're synthesized from other amino acids? Can you explain this? Also, can we talk about hypercatabolic states?
Sure, during rapid growth, the demand for amino acids like arginine and proline increases. They're typically synthesized from other amino acids, but the body might not keep up, making them conditionally essential. In hypercatabolic states, like severe illness or trauma, the body breaks down tissues rapidly, increasing the need for these amino acids. So, dietary intake becomes crucial.
Tell me a bit more.
Sure, in hypercatabolic states, the body's metabolic rate spikes, breaking down muscle for energy. This rapid breakdown demands more amino acids, especially those normally synthesized. Without enough dietary support, it can lead to muscle wasting and delayed recovery.
Okay, let's go back to lungs now. Let's talk about fixed obstruction.
Sure, fixed obstruction in the lungs refers to a consistent blockage, like from a tumor or scarring. It can cause persistent airflow limitation, leading to symptoms like shortness of breath or wheezing. Unlike variable obstructions, fixed obstructions don't change when breathing.
Hmm. Okay, that makes sense. So I imagine then that variable obstruction would be an obstruction that varies depending on inhalation and exhalation. Tell us about variable obstruction.
Variable obstruction refers to a condition where airflow in the respiratory tract is intermittently blocked depending on whether a person is inhaling or exhaling. Typically, this can happen with conditions like tracheomalacia, where the airway walls are more flexible and collapse during certain phases of breathing. This can cause symptoms like wheezing or stridor.
That makes sense. And so we need a lot of pressure to reopen the collapsed tissue too.
Exactly. When the airway collapses, it takes more effort and pressure to reopen it, which can make breathing difficult. This is why people with variable obstruction might experience shortness of breath or noisy breathing.
Interesting. So in a flow volume graph, is the inspiration always the y-axis going down and the expiration going up, or does this vary depending on the graph?
So, on a flow volume loop, inspiration is typically plotted above the x-axis and expiration below it. The shape can vary with different conditions. In variable obstruction, you might see a flattening of the inspiratory or expiratory curve, depending on whether the collapse happens during inhalation or exhalation.
Interesting. I have it the other way around. But basically, in expiration, we will have a decrease, decrease, decrease. And then in inspiration, I mean, I'm trying to visualize how will this look, you know?
Got it. Picture a loop where the exhalation curve typically rises quickly and then slopes down as you breathe out. Inhalation starts from the baseline, forming a more rounded curve above the x-axis.
This is what
With
I don't understand. So why in the inspiration we have a less sudden decrease in inspiration, but in expiration it's sudden?
It's all about the dynamics of airflow. During exhalation, you're pushing air out, so the flow is usually more forceful and sudden. Inhalation, on the other hand, involves creating a vacuum to pull air in, which is often a bit smoother and less abrupt.
So it makes kind of sense because when we inspire, it's a decrease that's kind of gradual. When we expire, it's like expire a lot, expire a lot, expire a lot, and then expire nearly nothing. So that makes sense. One thing I was wondering is why this is the way God or nature or evolution made us.
It's fascinating, right? The design helps us efficiently exchange gases. Rapid exhalation clears CO2 quickly, while controlled inhalation optimizes oxygen uptake. Evolution's fine tuning at work.
So what's the difference between extrathoracic and intrathoracic variable resistance?
The difference lies in where the airway narrows. Extrathoracic resistance happens outside the chest cavity, like in the upper airway, and it typically affects inhalation more. Intrathoracic resistance is within the chest, often affecting exhalation. Both can cause breathing difficulties, but in different phases of respiration.
I see. That makes sense. Uh,
Yeah,
Excuse me. So what is inflation and deflation?
bless you. Inhalation is when you breathe air into your lungs, while exhalation is when you expel it out. It's the basic
Deflation,
cycle.
deflation is the same as expiration.
Exactly. Deflation is just another term for exhalation, focusing on the lungs releasing air.
Interesting. Okay. Interesting.
Glad you found it interesting.
Okay, so let's say we have positive pressure on the x-axis and on the y-axis we have air volume.
All right, with positive pressure on the x-axis and air volume on the y-axis, you're essentially plotting how much air the lungs can hold at different pressures. This helps understand lung compliance and capacity.
And so how come the graph of kind of air volume positive versus positive pressure has the inhalation. It is this loop. I just wonder why the bottom part is inhalation and the top is expiration.
So on a pressure volume loop, the bottom part shows inhalation because as you increase pressure, the lungs fill with air. The top part shows exhalation, where decreasing pressure allows the lungs to empty. It forms a loop because inspiration and expiration create different pressure volume relationships.
But it's weird to me because when I was saying to you before that so we expire more fast. So do we or do we not expire more fast towards the end of exhalation compared to the rate that we inspire during the end of inspiration? Because in this graph, it maybe I'm mistaken, but it looks like we have kind of the same pattern in terms of rate during late inhalation and late expiration. What do you think?
You're right that the pattern can look similar, especially on these graphs. However, in real life breathing, exhalation often feels faster at first because it's more passive and driven by the natural recoil of the lungs. Inhalation requires active muscle effort, so it can feel more gradual.
Well, why in this mechanical ventilation graph that I've told you with y and x axis that I've already named, inhalation and exhalation look like this? Do you know the graph I'm talking about?
I think I get what you mean. On a mechanical ventilation graph, pressure volume loops show the relationship between airway pressure and lung volume. The shape reflects how the lungs respond to the ventilator's pressure. Inhalation and exhalation phases look distinct due to the mechanical assistance.
Okay, so what's the difference between type 1 and type 2 respiratory failure then?
Type 1 respiratory failure is characterized by low oxygen levels with normal or low carbon dioxide. Type 2 involves low oxygen and high carbon dioxide, usually due to inadequate ventilation.
Tell me again, I am confused.
No worries. In type 1, the issue is oxygenation, like in pneumonia, where oxygen can't get into the blood well. Type 2 is about ventilation, like in COPD, where carbon dioxide builds up because you can't breathe it out efficiently.
So in type 1 it's oxygenation and in type 2 it's CO2 buildup.
Exactly.
So
Type
what
1 is
what
low.
about if it's both?
If it's both, that's often called mixed respiratory failure, where you have issues with both oxygenation and ventilation. It's more
Interesting.
severe.
So, guys, I'm gonna stop here. This is part one of macronutrients and lung obstruction and oxygen therapy. Part two is gonna be uploaded in a bit. Thank you for listening, guys, and see you later.
Great session. Looking forward to part 2. Take care.